Okay, I did it. So I'm calling this Understanding Justice in Medicine in the Time of COVID. And please feel free to interrupt me as we go. So Martin Luther King is known for saying it's not possible to be in favor of justice for some people and not be in favor of justice for all people. And what he was saying is justice is really, really important, and equality is the basic idea, again, behind justice. And when we talk about justice, everybody says, yes, justice, that's terrific, but it's hard to articulate what it is. What is this guiding principle? So everybody thinks they know what it is, but they can't say it, and they all think we all agree on what justice is. So the discussions of all these important subjects all start back with Plato and Aristotle. And a professor of mine was fond of saying that you're born one way or another. You're either a Platonist or an Aristotelian, and I'm an Aristotelian. So Aristotle acknowledged the importance of justice, and he has important chapters in his important book, Nicomachean Ethics, about justice. And what Aristotle was amazingly insightful about was acknowledging that justice is very complex. And it's complex, and to understand what justice requires, you have to understand the context. So for example, he gives this as his example of what justice requires. He talks about someone who is going to return a debt that he owes to a friend. Imagine somebody, good friend, you ask to borrow $5,000 and you're going to return it tomorrow, and the friend lends you the money and you have it in your pocket. You're going to return the money to your friend, and you get a phone call on your cell phone from kidnappers. They've kidnapped your father. So this is Aristotle's example of, do you return the money to your friend, or do you ransom your father from the kidnappers? And how do you know what to do? These are two important things: saving your father and returning a debt, keeping your promise. And he doesn't give us an exact answer, but he gives us this lengthy discussion. So determining what is just depends on the circumstances. So you have to think about the relationship. Has this been the father who supported you for the past 30 years, gave you every opportunity, loved you dearly? Or is this a father who begot you, but you haven't seen him for the past 30 years? So the kind of relationship matters, and the history of the relationship matters. And then there are the consequences. Now, if your father was 90 years old and dying from pancreatic cancer, and every time you saw him, he said, "I wish the angel of death would take me quickly. I've had enough of this. It's wasting my time and everybody's money, and I'm in terrible pain. I don't want it anymore." You might think more of returning the money to your friend. And if your friend was Mike Bloomberg certainly doesn't need your $5,000. So that would be an important element of the facts to determine whether you're going to ransom your father or return the money. So for Aristotle, you have to look at the facts of the situation and what's required. He talks about practical wisdom. I'll call it moral discernment is required for making a just allocation. And you need this moral discernment to identify the factors that are significant and determine how they should be compared. So that's an Aristotelian view on what justice is. And the answer is, it's complicated. Tell me the facts and we'll figure it out. Now, when you think about justice, we all know about justice. And again, it's not one simple thing, in my experience. So if you go to buy pizza and you see the person just before you gets a very nice large slice, you don't want to get a small slice. You want an equal share. Or if I'm playing Monopoly with my grandchildren, at the beginning of the game, everybody gets an equal amount. If you're going to the movies again, once they open up, it's okay to give out seats at the movies on the basis of first come, first serve. But if you're giving charity, you want to give it to the people who need the money. But when we're giving out Nobel Prizes, you give them out based on who's contributed the most in the past. But if we're choosing people for the Olympic team, we don't think about past contribution. We think about who's going to bring home the medals, who has a good chance of winning. And sometimes it's age before beauty. And sometimes to your Seder, who do you invite? You invite your nearest and your dearest. Sometimes we think about, I'm giving out some scholarships, who's going to benefit the most from it? And sometimes if it's a lottery, everybody gets a chance. And sometimes we think about giving most to the people who've been unlucky. So in everyday ethics, we have a variety of different principles of justice. And when we say that we're making a particular kind of decision, what it means is we're picking one of these principles and we're saying that the other principles are not appropriate for this kind of decision. Now, most of the authors who write about justice, they're very concerned with trying to identify the right answer. What is justice? And the way I talk about it, they have a very essentialist view of what justice is. They're trying to think of justice as being a simple thing. And one of the most prevalent views in bioethics today, the basis for the national health system in England, is utilitarian ethics. And utilitarian ethics is the creation of Jeremy Bentham and John Stuart Mill. And what utilitarians do is they try to identify an objective standard, one standard for calculating outcomes. And for Bentham, that was pleasure. And for Mill, it was happiness. But utilitarians will pick out one thing. In the national health system, they pick out life years. So they employ that single standard in determining policy and making policy decisions. And they aim at maximizing it. So in the national health system, they decide what to fund based on what's going to give them the most life years. And utilitarians treat people as equals. Everybody gets counted the same. One life year is one life year, whether you're 20 years old or 50 years old, whether you're going to spend it as a couch potato in front of the television, or whether you're going to be doing great work in the laboratory. People are all equal, and they deliberately ignore relational and relative differences between individuals. So, for example, I have a very talented dancer in my family. Now, if I have money for ballet lessons, should I give it to the neighbor across the street, or should I give it to my granddaughter to have more ballet lessons? Well, if the neighbor across the street, if her daughter is more talented and more energetic and has more promising career, as a utilitarian, I should give it to whoever's going to produce the most happiness or pleasure or life years. And it doesn't matter that my granddaughter really wants those dance lessons. So people like the utilitarian view because it's simple, it's focused on something that people actually value, and it allows numerical calculations that makes all decisions the same way. So that sounds very fair. So I'm only going to talk about theories of justice that people use today in medical ethics. So very influential in the 20th century was John Rawls, known for his theory of justice and political liberalism, his two most famous books. And he gives us two principles that lead to a lot of discussion on justice. And his first principle is that justice requires a liberal, democratic political regime to assure that citizens' basic needs for primary goods are met. Basic needs for primary goods: food, shelter, housing, education, and that citizens have the means to make effective use of their liberties and opportunities. So this is his first principle of justice. And the second principle, and these principles are supposed to regulate basic institutions in a liberal democratic society. The second principle requires assuring citizens fair equality of opportunity and what he calls social and economic inequalities to be of the greatest benefit to the least advantaged members of society. So from these two principles, and the second principle, as you can see, has two parts, come important views about justice in medicine. So most well-known is Norman Daniels. So John Rawls was at Harvard, Norm Daniels was at Tufts and then at Harvard. And Norm Daniels is particularly attracted to the first principle, which is fair equality of opportunity. And Daniels argues that the allocation of healthcare resources should aim at equalizing opportunity. And he uses what he calls normal species function as the benchmark for deciding which care to provide, and nothing else is relevant. And Daniels' famous example is, imagine a child who's two children who are going to have short stature. So the pediatrician looks at them, looks at the growth curve and the statistics, and recognizes that both are going to be remarkably short. And in our society, having tall stature indicates that you are more likely to have more opportunities. So which of these children gets growth hormone? Now, one of them is going to be short because she has short parents. The other one is going to be short because she's growth hormone deprived. So she doesn't meet this normal species function standard. So for Daniels, he will give the growth hormone to the one who's growth hormone deprived, but not the one with normal growth hormone. So this is looking at fair equality of opportunity. He wants to give them both the opportunity to meet normal human functioning. And then from the second part of the second principle, we get from this difference principle views that are today called prioritarianism or egalitarianism, and they're pretty close together. If you read closely the authors who write about them, they will make a big deal of the differences. They don't amount to that much. One of the most important people writing about egalitarianism is Elizabeth Anderson from Michigan University, and I deliberately chose Anderson so you can see that some philosophers are women. They don't all have beards. Okay, so the prioritarians and the egalitarians are concerned about how individuals fare in relation to one another. So remember, the utilitarians, everybody gets treated the same. We don't care how badly off you were, how well off you are, everybody gets treated the same. One life year is one life year. But for the egalitarians and the prioritarians, they're concerned about making people, bringing them all up to the same level or advantaging most the least advantaged. So for them, Nothing else is important. So the egalitarians, the prioritarians, the fair equality of opportunity people, and the utilitarians, they are all identifying justice as one thing. So I want to give you a couple of examples, and I had a whole lot more, but I just narrowed it down to two to keep it simple, to give you an idea or a basis for thinking about who's right. So I'm the constructivist, contextualist, looking at the facts of the situation and looking for principles from that, as opposed to the essentialists who each have a view of one thing, which is justice, and if you agree with them, then the other guys are wrong. So let's look at the example of the aftermath of 9/11 and the flu vaccine shortage in the fall of 2004. So in the aftermath of 9/11, we were envisioning a large-scale medical emergency. So that morning was a primary election in New York City. I was driving in after casting my ballot, and on the road, I heard about planes crashing into the World Trade Center, and the ambulances and the fire engines started racing down the highway. Everybody made room for them. By the time I got to Mount Sinai, the institution was locked down, and they had to go through double phalanx of security guards, and they were preparing for what they considered to be, expected to be, a mass casualty event. So they were emptying out the hospital of everybody who could be sent home to make room for the injuries that they were anticipating. And they were collecting blood, but only O-negative blood. Literally, people who had already been anesthetized for surgery were woken up so they could leave the hospital, go home, and make room for the injured. So we were doing triage. And triage is the policy of avoiding the worst outcome. So this starts off on the battlefields back in Europe long ago. Napoleonic army, Napoleon very much for the citizens, recognizes not just the rich should have medical services, but doctors should service all of the citizens in the army. And there were big battles. And sometimes there weren't enough doctors and medical supplies to take care of everyone. So they came up with this idea of triage, dividing people into three groups. There were the people who were worst injured, greatest injuries, but not likely to survive. And they would need the most attention and the most supplies, and it was very unlikely that they would survive. And those people would be set aside. And then there were the ones who were expected to survive. And the most urgent ones with most urgent needs were treated first, and the ones who could wait a while were treated next. So triage involves identifying that this is a situation of a large-scale medical emergency, and we have to make these very draconian decisions, which involves not treating some so that those who are likely to be saved can be saved. So one of the places where we use triage every day in the hospital is an organ transplant. And I've been very involved with our liver transplant program for 30 odd years. And we list people who have less than 6 months to survive without getting a transplant. So they're all people in need. And if you're on the list and you develop sepsis, or you have a cancer that metastasizes, then you're either made inactive on the list, or removed from the list, because the likelihood of your survival is very low. And if we should allocate a liver to you, when you have, to somebody who has metastatic disease or sepsis, and they're likely to die anyway, you end up with the recipient dying and somebody else who could have gotten the same liver dying. So we take them off the list. We foresee that without a transplant, they're going to die, but one death is not as bad as two. So that's the principle of triage. And what we were doing on 9/11 was trying to decide who can leave. So the people who can wait, they wait for their medical treatment, and making room for the ones who we expected to be seriously injured. And we did not pay attention to whether a patient has previously received a fair or equal share of resources. And we did not look to see which opportunities people had in the past. So we adopted the principle of avoid the worst outcome, and we considered which interventions would lack efficacy. And we do that to maximize everybody's chance of being saved. And people accept that because it gives everybody a better chance in living than could be had by a different allocation scheme. And then with that principle in place, everybody gets treated by the same principle. So it's not that everybody gets the same amount of care, but the same principle gets applied to everyone in making all of these decisions. So the flu vaccine shortage of 2004, I remember it well because my daughter-in-law, Laura, who Rabbi Murray just mentioned, she was pregnant. And we recognized that fall that we weren't going to have enough flu vaccine for everyone. And we had to decide who was going to get the flu vaccine, that limited amount. Now, nobody wants to get the flu, but we all recognized that it was a limited amount. Not everybody who wanted it could get the flu. So government was very slow at making decisions, and communities around the country very quickly started making their own plans, and they advocated for their own policies. And what was remarkable about 2004 was that in every community, you came up with the same list. So the people who were prioritized were then the ones who were immunocompromised, the very young, pregnant women, the elderly, and healthcare providers. And the only people who I heard complain about the list were the pediatricians and the geriatricians. And the geriatricians thought their patients should get extra attention, and the pediatricians thought their patients should get extra attention. But everybody else thought this was a pretty terrific list. So my daughter-in-law, who I mentioned, she was eligible, and also her husband was, my son was eligible. And I remember my son coming home and saying, we were on the line to get the vaccine, and Laura did. And when I looked around at who was on the list, I recognized that all those people needed a lot more than I did. And my son took himself off the line so he didn't get the vaccine. So the principle there was avoid the worst outcome, which was at that time the most deaths. So avoid the worst outcome, you have to remember, you have to notice, is not utilitarianism. Utilitarianism is maximizing the outcome, life years. So from the previous list of the elderly, the immunocompromised, pregnant women, There was a fourth group. Immunocompromised. Oh, and children. Who would the utilitarians not have put on the list? Anybody can answer.
The elderly.
Not the elderly. Who else would not have been
The
on
young
the list?
kids.
Now, the young kids, they could die, and they have a lot of life years. You lose them, you're losing a lot of life years.
Oh, so maybe the pregnant.
The pregnant women, you get 2 for 1 you save.
Immunocompromised.
Yes.
The immunocompromised, right.
Immunocompromised.
So as soon as you recognize that the list from avoid the worst outcome is not the same as the list that the utilitarian would put up there, you're recognizing that these are different principles. So avoid the worst outcome is, I call it bottom up. You're thinking about what's the worst outcome, and you're eliminating the ones off the bottom, as opposed from the utilitarians who are more top down. Who's on the top, the most life years, they get it first. Okay, so again, what we did in 2004 deliberately ignored the individual differences that are relevant to fair equality of opportunity and prioritarianism and egalitarianism. These are different approaches to justice, and we've used them in different situations. Now, in thinking about these issues, philosopher Ron Green, he's up at Dartmouth, he said, the mistake is trying to decide such matters by reference to a single principle, a single consideration, and not necessarily the most important one. So there will be circumstances, kinds of allocations, where we may have several different principles all pointed in the same direction. But there are other circumstances where different principles will point us to opposite directions. And we have to choose which principles to sacrifice, which is most important in this kind of circumstance. So my first conclusion from these examples is there are several principles of justice, and they have a legitimate place in medical and public health allocations. And that justice requires allocations that focus on a specific practical problem, and they identify the principles that address broadly supported and compelling concerns. In other words, you get people who are seriously committed to living by whatever principle we adopt. And if you can get all of their agreement, we know we've identified the principle that's really important for this circumstance. In other words, what we're doing when we make these decisions about justice is what I call moral triage. We're deciding which factors should influence the decision and which should not, which factors are relevant for making the decision, which are not, and we have to make those distinctions as rigorously and practicably as possible. Now, as an overall view, I regard professions as a gift from society. What society gives to the profession is the power and authority to do their work, things that no one else is allowed to do. And society gives the medical professionals the power and authority to make decisions about which patients to treat first, which patients to not offer a liver to. These are all part of the powers and privileges that society allows to medicine. I can talk more about that later. I don't want to take us away from the justice concept. So the way we proceed is ask which principle or principles of justice are compatible with society's trust for allocating this limited resource in this situation. And if we have to make these triage decisions, we then have to ignore principles that maybe are cherished principles. It may be we have to set aside age before beauty. We may have to set aside priority to the one who has contributed the most in the past. They may be principles we like to live by, but to achieve some other goal, we have to set something aside. So when we think about medical justice, when we think about justice in everyday life, we're looking at this list. This isn't a complete list, but it's the good list I gave you before. And from this list, I'm asking you again, are there any of these principles of justice that you think should be set aside by medicine? Think of an extreme emergency, or even all the time. Are any of these principles inappropriate for doctors who think about how to allocate their scarce resources? Now, doctors are making these decisions every day in every encounter. If you've ever gone to a doctor's office and had to wait for an hour for your appointment, you're recognizing that the doctor is allocating that time, and we expect that there was a patient with more urgent needs that needed their attention first. So it's their time, their energy, their smiles, the decisions about who goes first, the decisions about who gets the liver transplant, and the decisions about who goes into the ICU. So do all of these principles, are they appropriate for medicine, or are there some on this list that are inappropriate for making medical decisions?
I'd throw out equal shares, past
Right,
contribution.
Equal shares, we don't cut up the liver and give out equal pieces to everybody. Thank goodness I don't need any. Past contribution, it doesn't matter. If Bernie Madoff needed treatment, he got treatment, even though we think his past contribution was counterproductive.
I'd also throw out my nearest and dearest.
Throw out my nearest and dearest. When it comes to ballet lessons, I'll think about my granddaughter, but for the doctor in the hospital, we don't think about nearest and dearest. Anything else you want to throw out?
First come, first served.
Right.
Yeah.
I remember being in the emergency room with my husband, and there was a call ahead from the chairman of family medicine to the chairman of emergency medicine, and that Dr. Rhodes is coming in with her husband who has something wrong with his foot. And we sat there. It was one of the days I was most proud of Mount Sinai. And there were about 5 people there before us, and all 5 got treated before us. And that's the way it should be. But you're getting the idea that some principles that are perfectly good for everyday life, my nearest and dearest, for inviting people for your Passover Seder, terrific. But it shouldn't play a role in the allocation of medical care. So here are some principles that I think are very appropriate for medicine. We don't have to go through the whole list, but what I want you to see is that there are a number of principles that we use in medicine, and I'm going to talk about the different parts of medicine next. So far, are there any questions you'd like to ask? Anything I can clarify?
Yes, when you started out, you indicated there was a difference between an Aristotelian and a Platonic perspective, but that's the last I heard of Platonic. Is Platonic related to the utilitarian position that you described?
So if you remember when you were an undergraduate and you learned about the Republic, the Platonic view is you get to the end of the tunnel and you see the light, the form of the good, the form of the true, the form of justice. The idea is the critical word, the. So where there is one thing, so I identify those other views, I call them all essentialists, because what Plato was interested in was what is the essence of the form of this concept, the essence of justice. So I'm rejecting all of them. So the argument was an argument against Plato. So I didn't talk about him. You know, he's a famous philosopher. Anything else? Onward. Now, so we finished justice. We're going on to medicine and justice. So my second conclusion, it's difficult to achieve justice in medicine, medical and public health policy because there is no single governing principle, no simple formula for success. And there are a variety of considerations that can and do legitimately support good policy. And policies must reflect the choices informed people cannot reasonably reject, and the priorities that informed reasonable people can recognize as the most pressing concerns in the situation. Now, an important problem is in medicine is that we have in the United States and around the world issues of people being mistreated and mistreated by the medical establishment, and that history of mistreatment gives rise to distrust. And even though the Tuskegee story got started with the best of intentions, what it devolved into has become a shame on all of us, and it has brought with it a lot of distrust from some communities. So my third conclusion is that different principles of justice should and do govern allocations in different domains of medicine. So just like different activities in everyday life get different principles, we don't use the same principle for giving out movie tickets as we do for who gets invited to the Seder. We don't use the same principles in different domains of medicine. So I've just made up these, what I'm calling different domains of medicine. I'll talk about non-acute care, which includes chronic care, well patient care, preventive care, and what I'm calling domiciliary care. Nursing homes, hospice would be domiciliary care. And then there's emergency care, critical care, and critically scarce resources, and public health. So here we go into medicine. So in chronic care, so imagine people with diabetes or people with renal failure. They have a chronic disease. We're not able to cure them, but what does justice require? It requires that we promote their well-being. We think about trying to maximize their advantages and minimize the burdens. And if somebody needs dialysis and you're building a new dialysis center, we think about where is there a shortage of dialysis centers and so getting to a dialysis center is hard for people, and we're going to prioritize those needs of people who are least advantaged. So at least three principles support the justice with chronic care, and whatever principles we accept, everybody gets treated by the same principles. Well patient care. Think of pregnant women, children. They have no medical needs. Nobody's sick. Somebody's waiting to get in. Oh, I can do this. If somebody else did it.
No,
Okay.
I've got them in. It's fine.
Okay, so we want to promote their well-being, and we want to develop interventions that are useful. And again, if there are some people who are least advantaged, we want to be sure to help them, and everybody should get treated equally. In preventive medicine, there we have a bunch of considerations. The anti-free rider principle, that nobody should take advantage of the cooperation of others, avoid undue burdens. So If getting a vaccine is especially risky for somebody who's immunocompromised, that child who needs the vaccine, who would otherwise be required to have a vaccine to go to school, can be exempt from getting that vaccine if it would expose them to extra risk. We want to pay attention to the disadvantaged. We want to figure out what works. Again, maximize benefits, minimize harms, provide things that are good public goods, like fluoride in the water for everybody. And again, whatever principles we pick out, everybody gets treatment based on those principles. When we're thinking about domiciliary care, those the nursing homes and the hospice, we're not trying to cure anybody. We're just trying to keep people clean in a nice, quiet environment and promote their well-being for everybody. And everybody, whether you've been advantaged or disadvantaged, everybody should have those concerns met. And then situations like this, these are emergency care. And in emergency situations, we think about first, what has to be done right away to save these people's lives. And after we think about what has to be done right away, we think about, well, what will maximize the interests and minimize the harms. And again, equality, everybody gets treated the same way. Now, these principles in emergency care for allocating the limited resources in the emergency room. Now, the emergency room in our hospitals today, we expect every patient who comes to the emergency room will get the treatment they need. So we're not exactly doing triage of setting aside a group. Everybody's going to get care in the emergency room. And what we actually think about is whose treatment is, who has urgent needs and who can wait a bit longer. So my husband with his broken foot, he'll have a little bit of more pain, but nothing terrible is going to happen by him waiting a bit longer. And if he doesn't try to put weight on the foot, it's not even going to hurt much. So we think about urgency, how soon a patient needs care to avert severe harm. We want to identify those with urgent needs and treat them first, and treat those who can wait longer later. And again, we're trying to maximize the chance of a good outcome and minimize the chance of a bad outcome. And beyond that, everybody gets treated equally. The same principles, equal means not that they get the same amount of waiting time, but that the same principles are applied to everyone. Now, emergency care is different from when we have a critically scarce resource, like in the intensive care units. And there we are using triage. We're trying to avoid the worst outcome, which will be 2 patients dying, when instead we could have at least saved 1. And once we make those triage decisions in the intensive care, the critical care unit, we will address whoever has urgent needs first and try to take care of all of the patients who we let in and treat them all equally. And in public health, we have a large array of principles because the situations can be vastly different. So the principles in critical care, where it's scarce, those are the times when we're allocating the critically scarce resources like ICU beds or transplant organs or ECMO or dialysis and ventilators in a pandemic, when we expect that there will be patients who we cannot treat immediately. And then we use triage, which is avoid the most avoidable deaths. And we pay attention to urgency, who has the most urgent needs of those who we plan to save, and treat everybody the same principles. So triage is the right policy, I believe. So what you're getting is my beliefs, all controversial, and it's going to get worse from here. Oops. Triage is the right policy for allocating these scarce resources because it minimizes everyone's chance of dying. If that's the principle, we have our best chance of surviving if we're survivable, and gives everybody a better chance at living than could be had with a different scheme. And it's the principle that people could not reasonably reject for governing the allocations of scarce critical resources during an extreme situation of scarcity. So
Could
John Rawls.
I ask a question?
Yes, of course.
Okay, well, it seems that one of the things that appears almost throughout most of the principles is the issue of equality.
Yes.
And yet I'm wondering about these kinds of situations. For example, if the president of the United States needed the same resource that you needed, should it make a difference? Or suppose there's enough to go around, like everybody standing in line for a vaccination shot at a hospital, and then the person who gave $2 million for that section of the hospital to be built shows up. You know, you're going to get your vaccination, but should they get the opportunity to go to the front of the line? So I'm wondering, where does the issue of equality get either to be flexed, or where do we kind of begrudgingly say, well, it's not so equal, but okay?
I think, so we have our principle that are usual, and then there is the context. So the person who gave $2 million or $20 million to build that wing, how much good could it do? So it's back to the example of Aristotle, and do you pay off the ransom, or do you return the debt? Now, it's going to be, how important is it to show that largesse will get you something, and how important is it to save that president? Is it, and there is no clear cut in stone answer. It's going to be, I think, very much turning on the circumstance. And one of the circumstances is how much trust will society have if they see that you're always deviating from your principles and giving priority to the rich. Or when I was in the emergency room with my husband, I had my Mount Sinai ID, full professor right there. Should it have made a difference? It shouldn't have made a difference then. Now, I'm at Icahn School of Medicine, and if Carl Icahn has the broken foot and he's going to give another, I don't know, $50 million, $100 million to build us some more needed space, I don't know what the answer is. I'd want to explore the facts. So if you look at my next slide, this blue one, you can't see it if your screen looks like mine. The equality column has equality checked in every single box. So there are the domains of medicine, and the point of this slide is to show you two things. One, that equality is always an important consideration, but it's, Steve, a consideration. And then to see the variety of principles, it's not the same for every kind of allocation. So again, I'm coming out on the side of the Aristotelians, where it's a matter of judgment. It's not simple. It's hard figuring out what's right, and you should always be worried about, could I have gotten this wrong? Okay, so many principles and different principles in different parts of medicine. And this is just a more focused view because I want you to focus on critically scarce resources, which is what we're going to be talking about when we're talking about COVID. Okay, how should triage be implemented in the clinical setting during a pandemic? So here we are. It was April in New York, not April in Paris, April in New York, and we had COVID. And we had, in the Mount Sinai hospitals, over 2,000 patients at a time. And starting in late March, early April, we developed an allocation policy, a triage policy for who gets the ventilator and who gets the beds in critical care. So I'm asking you more questions. What should be the principle for allocating beds in the ICU and ventilators? So the Aristotelian way of thinking, and there's a long history, it goes just the major figures in the history of ethics that adopted this view. It's Aristotle, it's Aquinas, it's Kant, it's Hobbes before Kant, and then Rawls, Scanlon, Honora O'Neill. So we have a whole tradition of people who've adopted this kind of view of it's all about figuring out the right principles and being able to give reasons for why the principle is right. So you're making these decisions. I had the job of writing the rationale for the Mount Sinai policy. How should we allocate the ventilators and the ICU beds?
Urgency.
Anybody?
Maximum benefit, minimum harm.
What? I didn't hear.
Maximum benefit, minimum harm.
Maximum benefit, minimum harm, and that would mean who gets the ventilator and the bed in the ICU.
Most likely to survive.
We went with the low likelihood of survival as our principle. So we went with triage. So in the clinical setting, now I'm making this, what I consider a very significant distinction between the clinical setting and the public health setting. In March and April, in the hospital is the clinical setting. Vaccine allocation is more the public health decision. So in the hospital, in the clinical setting, we went with triage. We identified those who were least likely to survive regardless of treatment. This was our policy. And we developed exclusion criteria. So again, this is the bottom-up way of allocating care. Who is least likely to survive? And the criteria is, could this individual, this beloved patient of ours, do you think it's likely that they will be able to survive until they're discharged from the hospital? Not a year, not 5 years, just to discharge from the hospital. Or do we expect that they're going to die in the hospital? And the second criteria, which was actually in a New York State policy far before COVID, will the individual be able to perceive the benefits of treatment? So if you think the person is like Terry Schiavo, never going to be able to have a thought again, we were going to exclude her from that care. And we were going to withhold scarce critical resources from those who met criteria 1 and or 2, and then provide scarce life-preserving resources. We're not giving it to them, it's just a trial of care. they have it as a trial. We'll give it to them and hope that it works, try our best to make it work. But if it's not working and they fall into criteria 1 or criteria 2, then we'll remove it. So then we reevaluate patients with critically scarce resources periodically, every 2 days, to determine their eligibility. Now, we created the policy, and I have to tell you that Mount Sinai was phenomenal. We never, ever had to put it in place. We took care of every single one of our patients. They created more and more hospital rooms. They converted regular hospital rooms to rooms for COVID patients that with the airflow pulling out. They removed windows and put in plywood and special fans, and they developed ways of converting ventilators, and hospital leadership and our board, they hired a plane to get ventilators from God knows where, and we never had to do it. But we had the policy in place. So did we have the right policy? As far as I know, there were some states and some hospitals where they had created policies similar to this. And I know of no place in New York State where they had to implement their triage policy. But we made it up with the expectation that we would have to use it. And it was a large team of people who all agreed on the same criteria. So now I've kind of explained it to you. Do you think we had the right criteria?
One way to answer the question might be to consider what other criteria you chose not to use. That way, maybe we could help, we could figure out whether we think it were the best criteria or
Well,
not.
it could have been, we could have made the standards higher. So there were places that had survived, not just outside the acute care setting, but survived for a year. We thought that that would exclude too many people. We expected, so I think you have to adjust your criteria based on the expected scarcity of the resources. So if we found that this survived outside the acute care setting, outside of the hospital, we saw people dying for lack of a ventilator, we would have to up it. So it would all be a matter of judgment relative to the situation, to the circumstances.
I have a question.
Sure.
I know you didn't have to implement this, but on your last evaluation, where if after 2 days you determine that a patient who is on a ventilator, let me get that clear, is not going to survive, would you have pulled the ventilator from that patient?
Exactly. Okay. Right now, as I told you about the liver transplant list. So it's not yet pulling the liver out of somebody, but we pull them off the list. And we tell people right at the beginning when they are listed, if your condition deteriorates to the point where you don't have the high enough likelihood of doing long-term survival. So in liver transplant, we want a 90% chance of 1 year survival and a 50% chance of 5 year survival. If we don't think you meet those criteria, we're going to remove you from the list. And they know it right away. And I mentioned back a slide or two, ECMO, this extracorporeal membrane oxygenation.
Oh, yeah.
We do that regularly. If we can't revive you, we're not going to keep you there until rigor mortis sets in. When we could be using the machine to save someone else.
When you mentioned earlier, as an example, you happened to just throw out the circumstances surrounding the death of Terry Schiavo. It prompts this question, a broader question, which is, given that your talk is being sponsored by a Jewish organization, synagogues, could you say something about the extent to which the ethics that you've been talking to us about, or ethics in general for medical situations, are affected differentially by a Judaic code versus, or by Judaism versus whether we would be hearing something different by virtue of a different religion or different religious perspective?
I think that's the question that Rabbi Morit will have to answer. I'm Jewish, but I'm not a scholar in that realm. And one of my dear friends, Rabbi Noam Zohar, who's at Bar Ilan in Israel, he has taught me about alternatives in Jewish medical ethics, that you can find stories in Jewish medical ethics that will support going either way. And for example, one of the stories he's told comes to mind because he tells the story of, does a community have to impoverish itself to the point of where people will starve to ransom somebody who's been kidnapped? And the answer is no. So I think there's a legitimate place in Judaism for thinking about the consequences to others and not just the patient in front of you. They're all our patients. And I think in terms of saving at least one, when otherwise two would die, I hope that that's something that the Judaism that I attach myself to could endorse. But I'm not the halachic expert.
Well, thank you for bringing that up. And also thank you, Dr. Rhodes, for bringing up that the sources in Judaism ask multiple questions and throw out different criteria, and will always ask these same questions. But what if it's in this situation or in that situation? And yes, there are circumstances in which the greater good is weighed against the individual. But then there's also these circumstances in which the question is, do I give up my own chance for life for somebody else? And that is debated as well. And where it also says, your life is just as valuable as anybody else's, and if it's yours, you must care for it. So it runs the gamut, and there are often more questions than answers.
Okay, onward. So now moving to the public health measures, where we are now in the pandemic. How should triage be implemented as a public health measure during this pandemic? So let's talk about some facts about COVID. So SARS-CoV-2 is a new coronavirus that emerged in late 2019. It quickly spread around the world, infecting and killing humans in its wake. And the disease, COVID-19, is airborne, highly contagious, and deadly. And these viruses reproduce and mutate very, very, very rapidly. Now, the experts, lots of them have said the same thing. And what they say is, until we contain the SARS-CoV-2 virus, we cannot provide social benefits. And without stopping the spread, we will not be able to reduce COVID-related mortality and morbidity. And they also tell us that vaccination will significantly reduce the likelihood of contracting and spreading COVID. So the question is, who should get the vaccine? Do I have the right side? Now, okay. Go back. So think about COVID And the example I gave you before of the flu vaccine shortage. Now, if you have noticed the policy that we've developed for COVID vaccine, it looks exactly like the policy we had for flu. The elderly, the immunocompromised, who was ever likely to have the worst outcome. We don't know about the children or the pregnant women, so we've been leaving them out of it. But is COVID a global pandemic? Is it just like the 2004 flu vaccine shortage? I think it's not. So COVID is far more transmissible and virulent than flu. The disease spread for flu, it typically runs its course in spring and it disappears. COVID got diminished somewhat in the summer, but it certainly did not disappear. So with flu, we know a lot about the disease. We knew how many are expected to die every year. People really die from it, but it's a known number and we know what to expect. We also knew how to treat it. COVID, we did not know how to treat. We didn't even have any effective treatments. And we always have enough capacity for taking care of people with the flu. But what we expected from COVID was that we would run out of capacity. So in light of these facts, who should have gotten flu vaccine first? I'll give you one more set of facts. So which principles should we use? It's very perplexing. I think they didn't scratch their heads enough and worry about this enough. So, okay, this came out March 26th in the journal Science. This isn't a popular magazine. This is the scientific journal Science. And the outlined white spaces show you the share of the population, and the blue bars show you the contribution to infections. So what does this graph tell you?
These were the spreaders, right?
Wait, somebody's saying something.
At ages 20 to especially 49, but even as much as 64, they're contributing the most to the spread. So suggesting that they might be the ones to get the vaccine sooner to cut the spread.
That's what I think. That's exactly what I think. So the vast majority, it's something like 78% of COVID spread is attributed to the age group 20 to 49. And when you add in the 64, up to 64, you have something like about 90% of the COVID disease comes from the people 20 to 64.
Are you saying these are
The people, let me just finish the sentence. The people 65 to 100, they hardly spread it at all. And people like me, I've stayed mostly at home. I'm not spreading the disease to anybody. So all of the people who can work from home and don't need to circulate are pretty safe from the disease. But the people who have to go to work, what they get called the essential workers, they're traveling to work, they're intermixing with people while they're at work, and then they have to get home from work. They're doing a lot of circulating, and that's why they're spreading the disease. So taking the facts about COVID and putting them together with this, it's new data, but I figured it out in October. And I'm no scientist, I'm no epidemiologist. It seems pretty obvious who's going to be spreading the disease. Somebody was going to say something.
Yeah, I think you sort of answered my question, which was, are these the people who are getting the disease, or these are the people who are actually spreading it?
These are the estimated sources. These are the spreaders, the sources of SARS-CoV-2 infections. These are the people spreading the disease. The blue bars are the spreaders. The 80-year-olds, almost nothing. The 65-year-olds and up, very, very little, like 2%, 3%.
In the early stages of the spread of the disease, do we have any kinds of models or estimations on how many people in that age group from 20 to 64 would have been willing to take the vaccine based on the news reports that we've seen ever since this thing started of the young people saying, I don't care, I'm going to go out and have a good time. You old folks are just jealous that we can go out and have fun and you can't because you might die, but hey, I'm young and I don't care.
I don't think the demographics match what you're saying. So the people who are going out and working, they mostly take the vaccine. But when if you're talking about the early stages of the disease,
Yes.
So April, May, June, July, August, September, October, November, December, we had no vaccine. We don't get the vaccine until January. And so we get the vaccine in January, and the planning for it starts happening in October. So the National Academy of Sciences, Engineering, and Medicine, and the CDC, they issue their recommendations October and November. And they're all saying, give it out just like in the flu, because those are the people most likely to die. Now, the people most likely to die are also, for the most part, most able to shelter in home and not circulate. Now, is it fun? Not so much fun. Not seeing your grandchildren, not seeing visitors, not going to your bridge game, not going to synagogue, not fun. But it's just a little while longer. And even now, we're hitting this fourth surge. And you just look at what's happening every day in Michigan, and it's coming around the world. They had, in the Times last week, they had one day the picture of Europe. In March, the new COVID vaccine, the British COVID vaccine, was just in the UK. And by April, it's all over Europe. So what we see in Michigan now is going to spread, and it's now more transmissible and more virulent. They believe they for sure it's more transmissible. I heard one infectious disease doctor talking about from the wild type, the first COVID, it took about 5 minutes being exposed, and now it takes a minute or two of exposure. So much more virulent. And when you go back to this picture, these are the people. So in these groups, the 20 to the 49, they're almost doubling the number of people they infect relative to the population. They're spreading it. So if Rabbi Morit.
Yeah, I'm so blown away by this, and I'm wondering if you can give us any insight as to the discussion in the public health conversations as to these are the people that were getting the vaccine last. These were the last people to get vaccines, and I'm wondering if you can give us any insight into those conversations and decisions.
Every time I've brought it up, and I've brought it up in several conversations for American Society of Bioethics. There was something, I was a speaker on a panel from Wiley Blackwell, and there have been 3 or 4 different occasions. And the response is, oh, but you have to worry about who's most likely to die. Now, if you think about, we had deaths, a lot of deaths in the nursing homes. Now, who takes care of the people in the nursing homes? This is the 20 to 49 are the ones who are bringing in the disease. Now, once we learned how to prevent the disease by wearing masks, not very hard, it's not a lot of fun, but it's not real hard, we don't transmit the disease. So people in the nursing homes, we say now, all the experts are on TV saying the rate of deaths in the nursing homes has come way down. Why has it come down? The 20 to 49-year-olds, 20 to 64-year-olds haven't been bringing in the disease when they go to visit. And the healthcare workers and other people, the people preparing food and cleaning, they're wearing their masks. It's very effective. So if you control the people who are spreading the disease, it seems to me that you'll control the disease. And it's like I'm speaking another language. So when I have an hour to talk to people, you become convinced. I know I convinced my daughter and my son, but I think this only came out March 26th in Science. And the authors say it in very sotto voce, very soft voice, that are you guys crazy in the way you're allocating the vaccine? But that's their message. And they were actually, their focus in the article was on how much opening schools contributed to the disease. Now you could, I asked a good friend of mine who's an infectious disease doctor to look at the article, and he says, well, I'm not sure of their methods, but if their methods are good, then it's an argument for vaccinating first the 20 to 64-year-olds. But I'm in no position to say how good their methods are.
Then, excuse me, how do we explain the number of people in nursing homes, workers, or the number of people in hospitals, the workers who are refusing to be vaccinated?
Well, in the hospitals, there is a number, and irrationality, anybody could get it. I don't know. It's not the brain fog, but it's some other kind of faulty thinking. Some of it, a lot of it is like any other vaccine hesitancy, real fear from the stories you've heard. And there are a lot of stories going around. But I know in my hospital, the number of people, the number of healthcare workers who have contracted COVID, they're working, taking care of very sick people, and they're working, doing things very close to their faces and around them in the same rooms. It's the infection rate in the hospital is less than in the general population, which tells you that with careful, even if they're not taking the vaccine, if they're scrupulous about wearing the masks and washing hands and keeping distance when you can, you don't get the disease.
Yeah. And unfortunately, we have too many people who consider public health measures political and don't follow them.
That's the point. It's so politicized. Today in Congress, Jim Jordan got up and was berating Fauci for when are you going to give us back our freedom of not to wear masks? You know, and going on, you know, shouting this until finally because he's on a committee, but he's not in charge now, until finally the one who's in charge of the committee shut him down. But he was there shouting, blaming Fauci for taking away his rights. And this is being espoused by other politicians, and it has become too politicized So you've got this small segment of the population that will take that, and that is now, and especially since they're talking about another wave, but they're saying, it's just such a small percentage of the population that gets sick, and that they shouldn't have to wear masks, they shouldn't have to take the shots, and just going on like that. It's become too political. And
I just want to have a little bit more to finish. And so this is another important point about the triage policy for who gets the vaccines first and last. So I think we should identify those who are most likely to spread the disease and identify those who are least likely to spread the disease. And also identify the harms caused by the disease. And the only harm that they're looking at is death. And I think there are a lot of other harms that are really, really important that have been completely ignored, like the impact on the young, the psychological impact. There are diseases that really affect young children that are very serious. Just the loss to them that will live with them forever of losing a year or more of education, of losing the time socializing, losing the experience of doing athletics together. Then there are the experiences of the long haulers. Nobody knows how long those symptoms will last. Nobody has a clue of whether the conditions will get worse or fade away. And then there's the issue of comparative harms. So from my point of view, if you have a pain and it's short-lived, it's not nearly as bad as one that's long-lasting. And if you die and you miss a year or two of life, that's not nearly as bad as losing 30 or 40 years of life. And those kinds of comparative harms and comparative burdens tell you, again, that the young should go before the old, in my way of thinking.
I think you missed an important impact on the young, and that's the young who lost a parent or a grandparent.
That's another one. Somehow I lost my slides.
Yeah.
So I did say in the last slide that flashed by, thank you, and thank you for your attention. And any other questions we can talk about.
Thank you very much.
Okay, I'll stop sharing. David Rosenberg is here. And Benjamin Rosenberg is here. And I should introduce my Aunt Esther, that's Estelle Sloan. The ganze Mishpacha. Okay, any questions I can answer? Or you can talk to each
I
other.
will say thank you very much. I do need to leave though, but it was
Okay.
very interesting.
Thank you, Suzanne.
And I have agreed with your philosophy even before I heard it. I felt also that I, as an old person who's been indoors and not out in the world, should not have been the first to get it. And I did. I was among the first that got it when that got the shot when it appeared in Westchester. I was by age that I don't get out. I haven't been out in a year, so that it should go directly to the people who have to be out in the world, and therefore can be both transmitters and recipients of the disease. So,
you know, I'm that chart just it was really a revelation. It sort of reminds me of, you know, you put the finger, you plug the hole in the dike rather than do a lot of mopping up, right? So if you have this huge disease, you know, you stem the flow of the disease, because that is going to make sure that everybody upstream and downstream stays safe and stays healthy. So I'm so surprised. I'm so surprised about it. I mean, you say that this is just from March, so so we have this month now. Now we have policy that says everybody, mostly at least in New Jersey, as of April 19th, as of 4 days from now, is eligible for the vaccine.
Thank goodness.
Yeah,
But there's still lots of places are still prioritizing the elderly. And in England, they're priorities. What I can't get is that they say we can't get any of these benefits until we contain the disease. And then they take a path that's diametrically opposed to containing the disease. And in England, it's strictly by age. So first, the 95-year-olds got the vaccine. Okay. So thank you very much, Dr. Morit, and everybody for coming.
thank you. This has been incredible. Really taking us from the theoretical and the philosophical underpinnings of justice, how it is applied to how we think about one another in society as well, then medical care, and then to today. You've done, I think, such an incredible job of distilling a lot of very complex, I mean, if we threw the Jewish stuff in there, that would have been a whole nother layer, but complex layers of important information in a way that we can understand it and really come away enriched by the experience and understanding the way in which doctors and institutions, as well as public officials, have to make these decisions. So thank you so much. This affects all of us, and we have no idea how much. So I'm very, very grateful. Uncle Beth-El and the other synagogues, really, I want to thank you so much for your time.